And so we have another alternative now, which was
very advanced.
Yes, which
the
is
UTI vaccine.
UTI vaccines. So UTI vaccines actually is not something new. It has been around in Europe for quite a long time already.
I think I only read about it recently.
This year.
So people are usually very surprised to discover that it's not like rocket science. It's not something that just came out yesterday. Okay. One of the vaccines that we currently use at our clinic is a tablet that contains 18 strains of heat-denatured E. coli. So E. coli, is a bacteria that is responsible for most of the UTIs that people get. Okay, and E. coli is normally in the gut. All right. So the vaccine is to be taken every day for 3 months. And this vaccine helps the patient to develop immunity against E. coli.
Does it help with like food poisoning or something?
No, it doesn't help with food poisoning. Yeah. So perhaps it does. Okay, but it hasn't been studied for that. Yeah. So it has been shown to help to reduce the frequency and the severity of UTIs. Okay, and for my patients who come to me, if they've had previous culture results growing E. coli, then I will embark them on this course of Urovaxom. So that is the the UTI vaccine that we have.
After 3 months, you don't need to take it anymore.
Yes, so then we wait and see. So I'll tell my patients that while they are taking the UTI vaccine, there is a chance of...
They're not fully protected.
Yeah, so they may still get a UTI. And when they do, they continue taking the vaccine and they take the antibiotics to clear. But it has been actually pretty good, So many of my patients have been UTI-free for quite a while.
After taking that for 3 months.
Yeah, but you do know that, as with cells, there's a turnover. So we might lose the immunity after a while. And there is no strict guidelines as to when to give a booster, but I will go clinically. So they'll come back and see me in a few months, after completing treatment. And then we will decide if they want to take a booster and then how what is the regime that we want to start them on if it's a booster.
E. coli, right?
Yes.
That's only for E. coli.
Correct. So we have another vaccine that's available. It is actually a vaccine that covers 4 different bacteria.
That's a lot.
Yeah, so E. coli definitely will cover E. coli. It covers Klebsiella pneumonia. It covers Enterococcus faecalis and Proteus mirabilis. So 4 bacteria that also commonly cause UTI. And it's a spray. So I actually brought a sample.
Oh, it's a spray?
Yes, it's a spray that the patient spray under the tongue. So it's just 2 sprays under the tongue. Okay, and it's also a 3-month course.
What does it? It's like every day, then 2 sprays.
Yes, every day 2 sprays.
What's the flavor?
Pineapple flavor. So if people don't like pineapple, then there's going to be a trouble. Okay, so this one, it is good for patients who can't swallow. Yeah, right? Because the earlier version, so some of the elderly patients may be on a nasogastric tube. And then this makes it easier. And this one, it doesn't have to go through the gut. It's absorbed into the mucosa already.
And it's on the go that you don't have to bring water and then swallow anything.
Correct. So you can't eat or drink water or brush your teeth or drink water, for 30 minutes before and after administering the vaccine. But after that, you're good to go. The only slight trouble is that it has to be refrigerated. Yeah. So
you can't bring it on the go anyway.
That's why I just now you're worried about me spraying this, but this is just a sample that I show my patients. Basically, when patients go traveling, I remind them that they have to bring a little cooler bag and then put an ice pack inside. It is okay to bring it traveling, even though it's not a refrigeration temperature.
There's definitely some kind of like storage.
Yes.
If you take it out of refrigeration, you can keep it.
You can keep it for about a month or so. But yes, the manufacturer has said that it's about a month. But generally, the moment they get into the hotel, they check in already. I just tell them to put it in the refrigerator. Yeah, so this has been pretty useful as well. And in fact, in nature, this recently, there was a longer term study, and then they found that at 9 years, right, 50% of the patients did not have a recurrent UTI.
After taking this for 3 months, then 9 years.
Yes.
Wow.
So that's pretty good results. Yeah. So again, I have to stress that they have to be patient because during that 3 months, they might still get a breakthrough UTI. And even for that 50% that may get a recurrent,
It's not like a
usually
lot.
it's not so
Oh,
bad.
it's not so severe, yeah.
Yes, correct. The symptoms are not as bad, and they respond quite quickly to antibiotics. And then the interval between each UTI is usually longer.
So Dr. Koh, is this for like everyone or is based on your doctor recommendation?
Yeah, so I was telling you that the vaccines only cover targeted bacteria. So if the bacteria on the culture that the patient has had indicates a different one out of, the
It wouldn't even work.
Yes, it wouldn't work, then I wouldn't recommend this for the patient. And I was telling you all earlier that the vaccines are not available everywhere. Only certain urologists have the vaccines. So you won't be able to get a prescription to go to a hospital pharmacy to buy it. Because it's on a named patient basis at this point in time. But I'm sure that in the future, because it is so efficacious, right, that it should be more readily available.
More demands, per se.
Yes. And it is certainly better to prevent than something, right? Medical Healthier SG about prevention, being healthy rather than getting the disease in the first place. Yeah. So if the patient has recurrent UTIs, I said that we will assess first on the suitability of these vaccines.
So far based on your experience, right? How's the side effect profiles? Is it very normal?
So it's generally well tolerated. For half of the patients on Urovaxom and Euromune, in the first 2 weeks of starting the vaccines, they may have very minor to moderate gastrointestinal side effects, like a bit of bloatedness.
Nausea, vomiting?
No vomiting. Nobody has vomited, okay? But maybe a bit of decreased appetite, a change in bowel habit, but generally, as if on cue, by the second week, it kind of normalizes already. And then they don't notice any difference. But for half of the patients, right, there's no change at all from the beginning.
symptoms at all.
Yes. So I usually warn them first, right, that, you might experience this, but don't give up. Usually after that, things get better. In some studies, right, for the Euromune, there was an increased risk of fungal infections, but very, very small percentage, very small.
How big was the study?
It's a small study also. So the thing is that from my point of view, it is very likely it's because that these women who have to start on this already had multiple causes of antibiotics and are already more prone to develop. Yes, so that's my feel, my take on that. Yeah.
So other than UTIs, what are other common complaints from your patients so far?
Common complaints. Okay. So I do see a lot of patients with urinary incontinence.
Okay, that's when they go when they shouldn't go.
Yes. So incontinence, the medical definition is involuntary leakage of urine. Yeah, so broadly, there are two main groups of incontinence. It's stress incontinence, not dealing with psychological stress, but physical stress, so that the patient leaks urine when they cough, when they sneeze, and then there is urge incontinence, where the patient has a sense of urgency first.
Keep going to the...
Yeah, usually, and then, you just going to remove your pants already, and then the urine leaks out. Sometimes at the door. They're just going to put the key in, and it's very urgent. Yeah.
Oh no.
Yeah.
Okay, that feels, actually that doesn't really sound, it just sounds like they didn't make it in time.
Yes.
But it's actually considered incontinence.
Yeah, so they didn't make it in time. So the urine came out before they were willing for the urine to come out.
Would you say that is because of some muscle? Because it's actually determined by the sphincter, right?
Sphincter, yes.
Yeah.
So the stress incontinence, the one that you leak urine with physical exertion, generally that is due to a weakened pelvic floor. And I usually see that in women.
Is it age-related?
It can be age-related because as we get older, especially after menopause, without the estrogen effect, everything thins out, dries out, okay? And then pregnancy also, especially childbirth, especially a traumatic childbirth. Okay, like sometimes patients need help to deliver, like they need forceps delivery or vacuum delivery, and there's a little bit more damage to the pelvic floor. So after that, the pelvic floor is weakened, and the sphincter control is not so good. So that is quite common. Some women who even didn't have normal delivery, right, like a cesarean delivery, can also experience. And I also have patients with no deliveries too.
Okay, yeah, that's true.
So if there's a lot of constant pressure, like chronic constipation, because you're always pushing down, bearing down, right? Okay, or if you have chronic cough and there's a lot of pressure down below.
Chronic cough.
Yes, after a long period of time, and for those especially who are overweight, there's a lot of pressure on the pelvic floor that can weaken the pelvic floor too.
It's kind of like multifactorial.
Yes,
then
it's
could be lifestyle.
multifactorial.
Just for everyone's understanding, what exactly is the pelvic floor?
Okay, so the pelvic floor, again, we will refer to this model here. It is basically the muscles that we are sitting on, okay? So there are sphincters that keep us from pooping, leaking poop, and there's a sphincter separately that keeps us from leaking urine. So it's like, you know those food saver clips that you have after you eat for a pop, right? Like those prawn crackers, and then you clip it. So they just act as a seal. But if the muscle is weakened, then, you know, after clipping a very large packet and then you open it, you will see that it doesn't...
very
so
secure.
well.
The clip is deformed.
Yes, yes. And then so if the muscle is thinned out, it can't have that good seal anymore. And then that's how the patients will leak.
So when the patient would know that they need to see a doctor rather than just like holding on.
Yeah,
to
because I think, right, I've seen clips of those weightlifters. Then when they are going in for that big lift, then they pull and then it leaks. And it's just like, this shouldn't be pathological. It doesn't mean that they have to go and see a doctor, right? It could just be at that moment in that event because of that.
activity.
Because of the
And
activity.
maybe because of what they ate earlier. Okay, depends on, you know, if they drank
too much water.
Yes. But yeah, and you know, so a lot of things can, like weightlifting also, there's a lot of pressure. Yeah, so I should have brought that up too. That can also weaken the pelvic floor. If it is affecting the patient's quality of life, then definitely they should come and see us. So if the patient is a very active individual, doesn't want to wear diapers, or if your constant wearing of pads is leading to urinary tract infections, right? And sometimes with the diapers, they get all the nappy rash. As an adult, you know, the skin, the skin dries. You know, it's very itchy and very uncomfortable and red and angry.
I've seen some of those like diapers because they have to cover everything. It's generally for elderly, so that they can.
So that is that group, and then there's the mothers who they go to the trampoline park with their young children. And then they jump, and then they, oh my gosh, just leak, right? And then quickly walk off, and then cannot accompany the child anymore already. That's when they will come and look for me, look for help. So that for stress incontinence, we do have, I do tell them to embark on a course of pelvic floor exercises first.
Maybe a sample of like
okay.
one or
so
two
it's
exercises.
actually very easy. So I tell them to focus on the muscles that they would contract if they are trying to hold their urine or if they are trying to hold a poop, because it functions as one unit. So when you clench the muscles, right, both are activated.
It's like practices for the muscle.
Yes. So I will get them to set aside some time. I tell them not to do it when they are passing urine or when they are pooping. Okay, so they separate. Yeah, they go and empty themselves, empty the bladder already. Then they just find somewhere comfortable. You can do it seated. You can do it lying down. You can even do it standing. So I ask them to clench and hold the muscles for 5 seconds, and then relax for about 5 seconds. And then again, start another contraction and hold for 5 seconds. And then you do 10 of these contractions in the morning, 10 in the afternoon, 10 in the evening. Okay, and then if you can do 10 again before bed, that's ideal. And I tell them that they have to be very disciplined. So if you are an athlete, right, you will go and work out the muscles every single day. If you only go and practice once a week only, you're not going to go anywhere, right?
It's not going to help.
Yes. So when the patients come back and say, oh, I only did it one time last week, then you're definitely not going to experience any improvement. And I feel that they have to earn their surgery. So they have to do a period of exercises, and then we know it doesn't work. Then it's justified to do anything else, right?
You can't just anyhow go surgery, right? Because surgery comes with its own risk.
Exactly.
And if you can do it with pelvic floor exercises.
And they have to be patient to wait for results. So certainly with the pelvic floor exercises, they will experience some degree of improvement. Whether that improvement is enough or not for them to be happy with their quality of life, you know, then we will assess that at the next visit. So usually I'll see them about 1 month later.
1 month later, if they do 3 times a day, 4 times a day, it should help.
We do have some patients, right, who absolutely cannot do the pelvic floor exercises. It's just
non-compliant.
No, it's not compliant.
Oh.
I have really. So some doctors don't believe me when I say there are some patients that cannot activate the muscle.
No mind muscle
They
connection.
cannot, yeah,
to
it's just
the
like some people
pelvic
cannot
floor.
raise their eyebrows, right?
Oh,
Okay, like no matter how hard they try, they don't know how to control
Like
the
you're
eyebrow.
born
right?
with it, is it?
Okay, so some patients really don't know how to clench the muscle. And you can do everything else, but they just can't activate their muscle. Okay, so for this group, right, we can try to do a biofeedback where we put some electrodes around the sphincter. Then they come to our clinic. Then we have a computer game, and then there's a feedback, so they can try to make the dolphin swim through the hoops when they come. But basically, it's just to try to give them more time in quietness, in a relaxed space to
play
learn,
computer
to try to figure out how to contract that muscles. Then once they know already, they don't have to come back, right? Because it's just to learn how to clench those muscles.
I
Yeah.
want to try the computer game.
Yeah.
Very interesting.
So other than surgery, is there like any other treatment options?
Yeah,
for-
so surgery, so some patients with stress incontinence eventually may need surgery because the pelvic floor exercises are will not be able to help them enough. Then we will put in a tape to give the pelvic floor a support. Yes, it's a minimally, it's just 1 to 3 incisions, okay? And it is actually not a very major surgery, but because every surgery is a surgery as well, so patients will have to decide if they want to go for it or not, because the sling will stay in the body for the rest of their lives. So if the patient is planning to have more children, get pregnant again, there's going to be a lot of changes below.
Right.
So we will advise them not to consider surgery first until they are sure they have completed family already. There is an interim measure, okay? So we do have vaginal laser treatment where we use erbium YAG laser to basically heat up the vaginal tissue to about 65 degrees. It doesn't cause any heat damage or trauma, but it heats it up so that it stimulates new collagen formation, new vessel formation.
It's
okay.
like laser your face, but like you
Yes,
laser
yes.
your pelvic floor.
Yeah, it lasers, yes, and it helps the muscles to, like if you look at the histology, that means if you look at tissue samples before and after, there is actually a thickening of the tissue. Yeah, but I always tell my patients that this is not permanent lah. Okay, so
temporary?
so they do this treatment, which is 3 sessions in the clinic, 1 month apart. They still have to do their pelvic floor exercises, okay, and then we will see how it goes. But they have to be realistic that at the end of the day, they may need surgery when they're ready for it. Yeah. So that is the stress urinary incontinence component. And then there's the urge. I don't know if we want to move into that or not.
Is there a very big difference in
Yes,
terms of
it's very
treatment?
different. Okay. So urge urinary incontinence is a condition that can affect both males and females fairly equally. Okay, so for stress incontinence, it's more the females, especially menopausal, especially if they have had pregnant.
Childbirth is
Yes,
a-
but males backtrack a little bit. Males who have had prostate surgery
right.
can also have stress urinary incontinence because of a bit of damage
Yeah,
to
to
the
the
sphincter
pelvic
muscle,
Okay.
which sometimes cannot be helped, okay, because if the patient has prostate cancer, for example, they need to remove the entire prostate gland, and the prostate gland is sitting right on top of the sphincter, and then not just the sphincter, the nerve supplying the sphincter as well. So some of the men with prostate cancer surgery may have stress urinary incontinence too, and we will have to treat them accordingly.
Is that something that they can exercise?
Yes, they will try exercises first.
Is it the same
Yes, same
exercise?
exercises, same exercises. But if that doesn't work, then we might consider a sling surgery for them too. But the male sling is slightly different from the female.
That's
And we, for those who are leaking very badly, we actually do implant an artificial sphincter. Yeah, which is like a BP cuff in concept, Yeah, and it keeps it closed most of the time. And when they want to pee, they will have to deactivate it.
They have to
manual.
Yeah, because you want to
press
be
the
dry.
button.
You want to be dry most of the time, right? And then it's only when you want to release the cuff, then you have to deactivate it.
That is so cool.
Wow.
Yeah.
Like biomech.
There's
Yes.
it's really a lot of advancement that we're not aware of.
Yes. So there's all these things, these avenues that patients can explore if they do suffer from stress urinary incontinence. But going back to the urge incontinence, urge incontinence is the leakage of urine when you have a sense of urgency. And if it's something new, then we usually think of urinary tract infections.
All right, because that's one of the symptoms, right?
Yeah, because the UTI is irritating the bladder and it's causing the bladder to contract, right? Because it's very unstable. So if the symptom is very new, then we will do urine tests for sure to exclude a urinary tract infection because that is easily treated. And usually with treatment, the symptom, this urgency incontinence should improve, okay? But if it doesn't improve, then of course we need to explore what are the other possible causes.
So for urge incontinence, it's something about the bladder rather than the sphincter?
Yes, so for urge incontinence, again, it is the sense of urgency first, and then the patient cannot control, and then the bladder starts emptying. So it's as if the bladder has its own brain already, okay? That your brain is not in control anymore of the bladder. So for these patients, we would make sure that it is not due to an underlying urinary tract infection.
Bladder infection, you think?
Yes, a bladder infection generally that is causing the bladder to be very irritable, okay? And we will treat the patient with a course of antibiotics if the urine test comes back as shows positive, or sometimes even from the history because they have burning feet, a sense of
Okay, right. There's other UTI symptoms.
Yes, then we can start first while waiting for the urine test to come back, the results to come back. So if it is not a UTI, then we will look for underlying other causes. So patients with neurological means nerve-related conditions, like if the patient has Parkinson's, Alzheimer's, previous stroke, this can also lead to unstable overactive bladder. Okay, so there's a neurological means a nerve-related cause for it. Okay, sometimes it is bladder cancer. Yeah, so bladder cancer can cause irritation of the bladder and give them urgency as well. If we have excluded treatable causes, okay, so many of times we will find that the patient has idiopathic means on its own. The patient just
like
has
no cause.
Yes, an overactive bladder or no identifiable cause. So we will still embark on pelvic floor exercises that we went through earlier, and then I would advise the patient, not just me, most urologists, to avoid triggers. So avoid taking
before you have that intense urge to go.
Time voiding, there's time voiding, but they can also avoid taking caffeinated substances like coffee, tea, alcohol, sometimes for some patients spicy food, for some patients chocolates also, but generally coffee and tea, okay, and soft drinks. So caffeine comes in Red Bull too, okay? Kickapoo? Does it come in Kickapoo? I can't remember. I think so. You all don't know what is Kickapoo, right?
I know, the yellow drink. No, what's Kickapoo?
Okay.
Also my time.
Yeah, okay, so we will avoid them, ask them to avoid triggers, and then we will embark on pelvic floor exercises and bladder training. They can do time voiding, but okay, so guess what is the normal capacity of your bladder?
I can't remember. I know this, but I
No need to know, you just guess.
The normal one.
Okay, 300. Okay, 300 is reasonable. So if you're watching a 3-hour movie or you're going to have a long drive up somewhere, sometimes you can even hold up to 500, 600 if you really need it, okay? But you might feel very uncomfortable. Or when you wake up in the morning and your first pee and you step very well through the night, might be about that amount. But let's say in the daytime, you know, we might go between 2 to 3 to 400, okay? About there. Okay, so in a patient with overactive bladder, they have a smaller functional capacity. So they might be they may be prompted to go to the toilet when the bladder has only about 100 mils or sometimes even 50 mils.
Very little.
You also feel like going to the toilet.
Yes. So for these patients, I'll get them to do a bladder diary. We actually give them a plastic cylinder, and I tell them to write urine on it, so nobody uses it for baking, right? Yeah, urine. And then just for 3 days, it doesn't have to be consecutive days, but for 3 24-hour periods, I get them to chart in their input and the urine output. So from that, we can see what is the average voided volume, the amount that they pee.
The frequency.
And we can see also the maximum voided volume. So I know what is their actual, what they can store and what they are used to emptying at. So I have patients, when I look at the chart, wow, it's only 50 to 80 mils each time, you know. And so, as I said earlier, we will exclude some underlying cause, but if there isn't, then I can embark on bladder training as well. So if it's a convenient at home, I will tell them that when they have the urge first, if they know they can delay it, then to try to do some pelvic floor exercises or something else to distract, and then to go to the toilet maybe 5 minutes later. So my example is, for those of us who have kids, right, when we toilet train our little ones, initially they're just peeing whenever, and then you just change the diapers whenever it's wet. But when the kid is about 2-3 years old,
You do the training.
The training, yes. So you bring them to the toilet at fixed intervals first, and then gradually you try to extend the interval.
Oh, right.
So your bladder is going to need time to eventually learn how to hold more urine. So it's not going to be an overnight thing. It is very easy to have an overactive bladder. Like after a UTI, somebody will be going to the toilet very frequent, and it takes quite a while for them to go back to normal. Yes.
Oh, it's because of the remnant effects of the UTI, or is it just
It can be, but for some patients it's not. It's just it's just used to it already. So it takes a while to train them. So if they improve, good. But if not, then they may need medications. Okay, so we have medications that can help to reduce the contractility of the bladder. We have medications to help to relax the bladder. Okay, and then we also have Botox of the bladder. Yeah, so it is actually a very simple procedure where through a scope I can put in a very small needle and inject Botox into the muscle of the bladder.
so it doesn't, so it relaxes.
So it helps to stabilize the bladder and actually works pretty well. So this is not the first step, obviously, because the first few steps would be everything else that I described earlier. But for patients who can't tolerate medical treatment because they have the side effects, then they might want to consider Botox.
Why is Botox? Why is Botox towards the end of the treatment rather
Because
than
it's
something?
still surgery. Yeah, but it is fair enough for patients with a lot of symptoms affecting their quality of life, and if they don't want to be on medications. Yes.
So for like other publics who are like not affected yet,
Yes.
then like is there any lifestyle advices that you can tell them perhaps to prevent this from happening?
Prevent, okay. I think just
The exercise?
good habits. Exercises, I would recommend that as we get older, for females, especially approaching menopause, to do pelvic floor exercises. I think we want to avoid urinary tract infections because that irritates the bladder. Okay, and then just drinking enough fluids and emptying at decent intervals. So we're not obsessed about how often should we go, but that the amount that we pee is about the normal capacity that we discussed earlier.
Thank you so much, Dr. Koh, for the sharing today. And me and Marie, like as a pharmacist, we learned a lot.
Yeah, we did. I think urological conditions, sometimes people will be a bit paiseh to talk about it, but it's also something good that we can share and let everyone know.
Yes, thank you for the opportunity to share today. Hopefully, with the advice that I've given you, you won't be seeing me in the clinic.
All right. So actually, we've got lots more to talk, but I think that's all we've got time for today. Thank you so much.
Thank you.
Thanks. So everybody, stay tuned for our next episode of the Clinically Speaking podcast.